Good afternoon or good morning to everybody, depending on where you're located. My name is William Noble. I'm one of the vice presidents here at Spectra MD. Thanks for everybody for joining this morning. My job today is a very simple one. I'm here to introduce our two very exciting speakers today. You want to go ahead and stand by. We have two speakers today, Dr. David Bernard. Dr. Bernard is the Chief Quality Officer at Continuum Healthcare Partners, Chief Medical Officer of Beth Israel Medical Center, Professor of Clinical Medicine, Albert Einstein College of Medicine, formerly Chief Medical Director of Care Management at Montefiore Medical Center. We're going to have a brief interlude between the two folks with a survey, and then Carl Osvelt, the Assistant Vice President of Quality and Performance Improvement at Center State Healthcare System, formerly Director of Quality for the Employer Division of United Behavioral Health, and Assistant Director of Quality at Pennsylvania Hospital, the Institute, will be joining in afterwards. Without further ado, I want to go ahead and turn over the control to Dr. David Bernard. He's going to be talking about all the things he's doing and experiences he has relative to preventable readmissions. Dr. Bernard?
Thank you very much, and hello to everybody. Let me just try to advance the slides here. Let me just see. Can you advance the slide for me?
I'm still on the front slide.
Dr. Bernard,
doesn't seem to be
you
advancing.
should be able to do it. Just click it a couple times.
Doing it. Here we go. Could you advance it to the next one? Here we go. So sorry for that little snafu. So I work at Beth Israel Medical Center, which is a teaching hospital of the Albert Einstein College of Medicine in New York. We have two hospitals, one in Manhattan, one in Brooklyn, part of a system called the Continuum Health Partners, a large system, as you can see, with over 2,000 physicians and a lot of employees. We have 1,100 beds, large discharges over, it's now about 55,000 academic programs, a lot of teaching programs, and a school of nursing, and a large ambulatory care center with all the visits you can see listed, and a very, very busy emergency department. So just give you a flavor of the size of our hospital, and it's part of a system. So let's talk a moment about readmission. So much of this I'm sure you're familiar with, but just to emphasize the importance of this issue, we know that on average about 20% of Medicare patients are readmitted within 30 days. A large number of these appear to be random. A large number are thought to be preventable. And patients in a skilled nursing facility, the number is even higher yet. The reason this has become front and center, of course, is the penalties that are now being implemented by CMS. But I should say this is really a quality issue, and in many ways we probably took our eye off the ball on this one. and indeed, in all the years I've practiced in hospital practice, we've known that as soon as the patient leaves the hospital, they're going to a big black hole, not managed well, and in a way this is giving us an opportunity to improve care across the continuum. So the new CMS rules involve the three core measure conditions, myocardial infarction, heart failure, pneumonia, but other conditions will be added. There's talk about COPD, diabetes, and maybe others pretty soon. The penalties, as you probably know, are up to 1% for 2013 and goes to 2 and 3%. You're talking about millions of dollars if you have a large Medicare population, as most of us do. And it has already been around for many years. In New York State, Medicaid are looking at the issue as well. And of course, as we move forward to new payment models like shared risk savings and bundled programs and capitation, obviously this becomes even more important. So the question you have to ask yourself before you begin a program is why does this happen? Why do patients get readmitted so often? So there really seem to be two main areas: poor transitions of care and then other. The poor transitions of care is what I said about a little while ago, which is patients are discharged we haven't paid attention to what happens when they go home. Clearly, there's other factors, and you could add to this list, and every week some hospital or system comes up with their favorite lists. There's a lot of these, and as I say, you can find your own, but non-adherence, confusion, medication's a very, very big one, multiple comorbidities, cognitive impairment, living alone, and other factors are very, very important. Now, what's also become important are two other factors to recognize. One is that many patients are readmitted for reasons other than their underlying disease. So in one study, 2/3 of patients with heart failure were readmitted for other reasons, and pneumonia, there's even more the case. So that becomes critical to manage the whole patient, not just the disease. But even more recently, emphasis has been placed on non-specific factors in a hospitalized patient. And I don't think people have paid attention to this very much. So it is the stress of a hospital, of being in a hospital. These patients don't sleep well. They don't eat well. They have discomfort and pain. They are somewhat overwhelmed by what's happening. Medications interfering with cognition. They're lying in bed and they get deconditioned. So all of these factors have to be considered when you're dealing with readmissions. And the patient goes home poorly nourished, deconditioned, maybe not so surprising that this is happening. This is a study that shows the point that I was making a little bit earlier, which is the reasons why patients were admitted. If you look at heart failure, 63% of the time it's for other reasons, with pneumonia 70% of the time, and so on. You get the message. So having understood why patients are being readmitted, what can we do about them? And as I look at this, if you follow the patient moving through the system, there are 4 key sites where you need to be paying attention. In the hospital, of course, which in many ways is the easiest because the patient's captive, sitting in a bed for 4, 5, 6 days, you can do what you need to do. In the patient's home, much more difficult. In the physician's office, and a key piece that needs to be connected, not always is, and in the emergency room, a very important area for focus to keep the patients managed and, if possible, avoid admission. And this is a slide that just puts it all together. In hospital, on the right-hand side, patient's home, the left-hand side, community physicians, and in the middle, we have the ED. So these are the 4 sites we need to focus on. So what do you do at these sites? Obviously, we could spend an hour probably in each one of them, but just briefly, the high level says the following. Top left-hand corner, in the hospital, make sure you identify patients. This is not so easy. Patients are admitted, called heart failure, have something else. Not called heart failure, have heart failure. So you need to have a system that identifies your patients well. You need to educate the patients about their disease, but don't spend too much time doing this because studies have shown patients in hospital, a bit distracted, lots of things happening, they don't absorb a lot. So you need definitely to focus on certain issues, particularly the drugs. Medication reconciliation is critical. Patients need to understand how to monitor themselves at home and who to call if they run into trouble. Don't just come to the emergency room, but they need to call their physician. And they need to leave the hospital with an early follow-up appointment, clearly within 5 to 7 days. If you do that, you've done well in the hospital. Now we get to the patient's home. 2 issues in the patient's home. They need to be monitored, and they need to be home visits. And I'll talk about the daily clinic just in a little bit. So monitor either by telephone calls or by telemonitoring or something like that. Home visits, obviously nurses are going to go to the homes. You might have physicians going to homes and then other people, and I'll show you that in the last slide. In the doctor's office, they need the discharge summary. They need to see the patient promptly, forget the daily clinic for a second, and then they need to understand the imperative of working together with you. And finally, in the ER, you need to be sure to know that the patient, when they come to the ED, were in the hospital and discharged within the last 30 days. We've put in place a flag in our electronic system that prompts the physician and says, by the way, this patient was recently discharged. You need to do what you can to avoid discharging the patient, avoid admitting the patient, I'm sorry. That may mean getting specialty consults, and I'll talk again about the daily clinic. So these are the highlights of the 4 areas that need to be managed and a highlight of the way to do that. And this, in fact, is my last slide that puts it all together. So let's just walk through a little bit. I've said most of this. In the hospital, we're going to teach patients about their disease and how to monitor themselves and who to call if they run into trouble and make the appointment. This is these are the sort of critical things you need to do in the hospital. Let's jump to the patient's home. That's over here. They need to be monitored. They can be monitored by telephones, by telemonitoring. And we have a system that we're studying in pilot fashion which uses a tablet with icons. So it's, if you will, it's sort of modern day electronic monitoring, which is turning out to be very interesting. And they need to be visited. They can be visited by social workers, physicians, pharmacists. We've had a program where we've been sending trainees, fellows and residents into the homes as well. And many programs claim these are the best. I've had a presentation from an organization that offers to rent you pharmacists to do this. They say that reduces readmissions. There's a program called the Bridge program, which has social workers in the home. So many people are trying different things, and the principle is you need to visit and monitor the patients. In the doctor's office, we've said all this. Get the discharge summary, make sure they're engaged, connected to specialists if necessary, and the medical home strategy is a very good one if you have one to manage these patients. And then in the emergency room, we've spoken about the highlights. The highlight, in my mind, in the emergency room is the ability to admit patients who are doubtful. What the doctors need to do in the emergency room is call, if they know the patient was recently discharged, call the specialist to come and see the patient, the cardiologist particularly. And if you can send the patient home with services, better yet, or to their private doctor. Failing that, if they can be admitted to observation status, as you know, that doesn't count as admission. They have 23 or so hours to be observed. That makes a big difference. I want to end by talking about this daily clinic. There are a few organizations around the country, and we're soon to start one. The notion of a daily clinic that is staffed by an RN or an NP that is available every day from 8 to 5 for patients to walk in unannounced. So they're at home and they're running into trouble. They don't know what to do. They know there's a nurse or nurse practitioner waiting to see them in a suitable area near the hospital where they can just walk in, ask their questions and have them answered, whether it's diet, whether it's exercise, whether it's symptoms, whether it's medication. The sort of daily clinic, everybody can use it. The ED can, community physicians can, patients come spontaneously from home. I believe that's going to turn out to be a valuable addition. I heard one organization made a presentation I heard with the advent of the daily clinic and observation, they had a dramatic reduction in readmission rate. And I believe we will land up with these two areas of focus being critical. And the home. Don't forget the patient's home. Monitor the patient carefully. Some people are doing daily telephone calls, but however you do it, keep in touch with the patient. Have the daily clinic available if you can, and I think we can get this job done. It is not easy, but by understanding where you need to focus your attention, I believe we will be successful. And I believe that's my last slide. It is, and thank you very much for your attention.
Thank you very much, Dr. Bernard. Okay, well, what we're going to do right now is we're actually going to take a break for a minute here and have a little poll. All the audience members, you get the opportunity to vote on this poll. It'll be appearing on your screen in a moment. And when it does appear, feel free to go ahead and click on the dot that most applies to you. So the question is, at what stage in the process of addressing preventable readmissions is your organization? So it's a 3 scope of choices. We've not begun, we have begun recently, and we're far along in the process. We're going to take about 30 seconds here, allow each and one of you folks to vote. I'm going to give you the results, and then we'll continue on with Carl Osfeldt of Center State Medical Center. Stand by. Okay, everybody. Well, thank you so much for taking the time to vote. I'll give you the results here. We have about 13%. Oh, wait, it's changing. 13% of the folks who have not begun the process at all. About half of you folks have recently begun the process, and 33% of the folks who are overachievers have gone very far along. So without further ado, I'm going to go ahead and pass this on to Carl Osfeldt. Carl?
Hi. I'm with Central State Healthcare System. As you can see up here, we are a moderately sized community medical center. You see that our inpatient admissions, our outpatient visits are somewhat less than certainly Dr. Bernard's. We do have a staff of 511 board-certified physicians. We have a pretty busy emergency department at 62,000 and change. We also, in addition, have a 94-bed skilled nursing facility. I'm sorry, our assisted living facility is 94 beds, 123-bed skilled nursing. And we also have a 430-unit continuous care retirement community. Very recently, we've become part of a New Jersey ACO with some of the St. Barnabas hospitals. Okay, there we go. As Dr. Bernard had mentioned, the penalties for readmissions in fiscal year 2013 were 1% of readmissions, or 1% of Medicare funds that the hospital received were at risk. And in our case, that was about $500,000. The penalty turned out to be, there can be a penalty of up to $1,200,000. We were very fortunate in the first cycle of readmissions in that we not only gained back our 5%, we gained about another $100,000 on top of that, but with a great deal, I'm sorry, I'm getting into the value-based purchasing, I apologize. So our penalty at current for readmissions is $1.2 million if we are on the same, if we continue down the same pathway that we've been on. The challenges we run into, and I think pretty much everyone has these same challenges, is all of our reporting is retrospective. Pretty much any of the data that we're receiving after the fact. If it's core measure data or if it's any data from the federal government, we're receiving it about a quarter and some behind the event. Our case management department has been focused primarily on utilization review. So the idea of doing something contemporaneously has been quite a challenge for them. We didn't really have the way to identify this group of people, so our care coordination faltered as a result of that. Plus, we weren't able to really take a look at how our initiatives were working, and that being said, we also didn't know what was going on outside the hospital. As Dr. Bernard mentioned, that large black hole outside the hospital. We wanted to be able to do the right thing, and in order to do that, we had to identify a trend in general, but on an individual patient as well. We wanted to be able to evaluate the processes we put into place. We, like a lot of you out there, undoubtedly, have tried things such as the RED project, the BOOST project, a number of these other initiatives, and all of it has had some degree of success, but it's been fairly difficult to actually evaluate how successful we've been. Excuse me. What we've been able to do with Spectre MD has allowed us to put together a problem and solution package that we're able to demonstrate with the stakeholders obviously being the board in the hospital and senior management. It allows us to facilitate compliance with the among the staff and among the patients. One of the things that's most important is that we're able to identify the at-risk patient in real time. The days of having a problem list where you knew exactly what diagnosis the patient had, or a working diagnosis, with the advent of the electronic medical record, that problem list on the front of the hard chart doesn't exist anymore. And we are challenged with the whole idea of being able to come up with a working diagnosis. One of the things we've been able to do is use a tool that is embedded in the CHF dashboard that allows us to determine a patient that's at a high risk for readmission with CHF. This was incredibly important. It was to figure out who exactly we were going to be dealing with in the first place. It allows us to focus directly on patients. We are able to integrate it into the hospital workflow, which allows us to work in a timely way. Everybody's aware of the fact that if you're looking at this situation after the fact, you're way too far down the road already. And it allows us to give information to the stakeholders in the hospital and try and chart where we're going, what kind of program do we need, what kind of program tweaks do we need, and allows us to evaluate the things that we have done and see their success. Again, the at-risk patients are identified as they come into the hospital. That algorithm that's being used is based on what was a simple readmission tool that's evidence-based, and be happy to share that information with the audience. It's a very easy to score kind of tool, but we're able to do that automatically with the dashboard. We evaluate the risk. We have a built-in case management component which allows the case management or care coordinators to be able to determine, have these kinds of things been done? Have the things that we know that need to be done in order to diminish readmissions, have they been carried out? Some of those things are, has the patient's appointment, has the patient gotten an appointment, as Dr. Bernard mentioned, within that 5 to 7 day period? We go so far as to actually arrange those appointments for the patient. Have they had their med reconciliation? And do they understand their medication? Has their educational process at least been started? In addition, the data are available based on your role. There are roles for the care coordinators or case managers. There's a role for the social worker who takes a piece of the responsibility. We also have a role for the VNA, who's here working with us as a strategic partner after the patient has left the hospital. Since we've implemented in January, this is the degree to which we are seeing the drop in readmissions, our readmission rate. Now again, the challenge is how quickly can we get this information, how quickly can we be able to determine what effect our interventions are having. But we've been able to reduce that heart failure readmission rate, and we've been able to reduce any potential readmission penalty. We're right in the midst of that data collection period for readmission penalty. When you're looking at the dashboard, what you're seeing here is you have the patient. This is based on an individual case manager perhaps. And you're seeing an individual patient with their admit date, and we know the days since the admission. We know that when their last discharge date was. Now this first patient, this is the first time they've been in here. But we see the second patient, Sam Query, who's been in here 2 days, but he's been out of the hospital for 45 days. We know what his attending is, and we know what his working diagnosis is. He's scored an 11, or a 13, which puts him into the red zone. This is somebody that we are pretty clear is going to be a readmission if we don't do something about the situation. So what you're seeing here is a dashboard that an individual case manager would have to take a look at and identify going after each one of those patients. Okay, what you're looking at is the individual cases. Now here, if you look at Mr. Query again, you can see whether while in the hospital, he's had his med reconciliation done. However, the patient education has not been documented. We're not entirely clear. Now we know that he has obviously not ready for discharge, so he will have his case summary sent to that community physician. He'll have an appointment with the PCP, and he'll also may or may not have an appointment with the cardiologist. And when they're in the patient's home, this is an area that the purplish area is there for the VNA to be able to document whether or not they've had the telemonitoring, and are they having RN and home or NP home visits. We are beginning to have physician home visits as an ongoing process available to us in Central Jersey. There's also the opportunity to write down what are those things, kind of a predictor of what are the elements that are going to be problematic or may cause this patient to be more likely to readmit. Okay, and you have two areas to document there. We're able to take a look at our trending over time, and you can see where they've been up and down, but we are within a reasonable rate at this point. This gives you the opportunity to take a look at this at the higher level. So the CMO and the quality officer are able to actually take a look at this, because we have not only CHF, but now we're moving into the other areas of different disease states. This is a version of the board that allows the Chief Quality Officer, myself, and the Chief Medical Officer to take a look at these cases on an ongoing basis. And by looking at that at a glance, I have some sense of where we're going to need to deploy the people and the patients that are going to need the most work, if you will. One of the things that this has allowed us to do, it's allowed us to reorient the way our case managers and social workers are actually working. This gives a very different way of looking at what the case management job particularly has been. It's not just utilization review any longer. It's actually affecting patients' care while they're in the hospital and their potential follow-up. It gives them an opportunity, it gives the case managers, care coordinators the opportunity to manage that patient at risk, and it helps change the way in which we follow up the patient after the hospitalization. Gone are the days, obviously, when that patient leaves the hospital and that's it. We have no further intervention with them. The things that we're looking for coming up, we're moving out into the AMI and pneumonia and additional chronic diseases. COPD and diabetes are some of those areas where we're looking to move to. The focused analytics also, we want to be able to move beyond the hospital and out into the continuum of care. As I mentioned, we have a skilled nursing facility, and we've been working directly with them to be able to determine how they can continue on with these patients that we've identified. We're putting together a post-discharge work list that the Home Health Service, the VNA of Central Jersey, is able to work with, that we take the information, share it with them, share it with the VNA, or with the skilled nursing facility or whatever facility we send the patient to, so they're aware of the things that have already happened with that patient. And that ends pretty much my piece of this conversation. We've been thrilled with the work that we're doing with Spectre MD. It's allowed us to actually get a handle on a group of patients that we all found very difficult and very challenging to get to. That's the CHF patients particularly. And we've had a demonstrable change for the better in our readmission rate for CHF.
Thank you very much, Carl. Appreciate your time going through those. So folks, we've got a few minutes now before we wrap up today to take questions, and we've had quite a few, so feel free at this stage to go up to the text box should be in your upper right-hand corner. That's where the program originally opened it. and there's a little box that says type message here. Feel free to go ahead and type your question in there, and we'll get to the answers. And so I'm going to start taking a couple of them. We've had a couple during the process here. And the first one is for you, Dr. Bernard. And the question came forward on the daily clinic. There's a couple of folks wondering how does a daily clinic get funded at a particular institution? Dr. Bernard?
I'm sorry. This is an important point. The organization that I first heard this from took the view that there should be no money, billing, charges, whatever. It should be an open clinic where patients can walk in and out without an appointment just when they have a problem. So this was funded by the hospital. It's an RN. They funded an RN position, and there was no charge to the patient coming in here. So, you know, you're looking at a bit of an investment on the part of the hospital, but if you consider the savings that go along with it, obviously it's a huge benefit, and we're probably going to do that as well.
Fantastic. Okay. The next one is for you, Carl, and there seems to be a couple of questions on how information gets into the system so that the dashboards can be generated.
Okay, those patients are identified. We have a combination of areas in which from which the data arise. The patients are identified in the admission, discharge, and transfer system. We use Meditech as an ADT system in this hospital. They're identified, and it's the crossover between these patients are being identified when.
Carl, we seem to have lost you there. Carl? Okay. We'll move on into the questions here. Let's see. We've got one for Dr. Bernard. The folks are asking a little bit more information about the daily clinic. How is information transferred between the daily clinic and the hospital? Is it, I guess it's a question that sounds like is it attached? Is it different? How does the information conveyed back and forth?
So the way this works is the nurse who runs the daily clinic comes to the hospital before the patient leaves, introduces herself or himself.
As the hospitalization or the time progresses, the case manager goes in there and verifies whether or not they're actually a CHF patient. The challenge has always been to cast as wide a net as we can to get all of the CHF patients and try not to get patients who are not CHF. So it's a specificity issue.
All right. Thank you, Carl. I think we're going to go back to Dr. Bernard again. Dr. Bernard,
okay,
if you want to go ahead and answer the question that we just had.
Yeah, so as I was saying, the nurse who runs the daily clinic doesn't stay in the daily clinic. She or he is also in the hospital, meeting the patients before they leave, introducing themselves, making themselves available to the patients, and then they're in this clinic. Now, you also have to have, obviously, people in the hospital that are doing the education and the setting up of the home care and the doctor's office, follow-up visit, all that stuff. Some organizations have a dedicated transition coach or case manager to do that. That's a good idea. We do have somebody like that. In other organizations, they use the hospitals, nursing staff, social workers to do that. That's fine too. But the nurse in the clinic is going to know these patients and keep in touch with them when she sees them. Now, the goal is to keep those patients out of the hospital. So where she needs to be most connected is with the primary care doctors in the community. And there's a handoff there. It's often a phone call or a fax to say, you know, Mr. Jones, your patient with heart failure was discharged 10 days ago. I saw him today because he was short of breath. I've spoken to him about his diet, and you will be seeing him in 2 days' time, or something like that. So that's the main communication is with the private doctors or the primary care doctors. Less so with the hospital, because you hope the patient won't come back to hospital. Now, if you happen to be using Spectra MD's system, there is a way of entering that information into the electronic system, another way of capturing these data.
Thank you so much, Dr. Bernard. Okay, we got another one for Carl here. There's a couple of them related to this, asking about what software you're using for the case manager dashboard, and several derivations therein. Carl?
Case Manager Dashboard is actually, this is built by Spectra MD, and it's the Focus Analytics software that they're using. And it works now. We're currently undertaking implementation of the McKesson case management system. Our hospital has a somewhat unusual financial system, and as everybody's probably aware, case management systems spin off of that financial system. So in our case, we're not able to buy an off-the-shelf kind of version of that. We have to go with a standalone case management system. So the folks from Spectra MD are working with the folks from McKesson to see how those are going to, how those interdigitate. But the main thing with the dashboard is the Focus Analytics.
Thank you so much, Carl. There is one here, I think it's for Dr. Bernard, related to how much is the care after discharge costing on average. I assume that's getting back to the question of the cost of the daily clinic or the aftercare relative to what you folks are doing there.
Well, if you put the clinic aside for the second, if you take a look at the costs, we use home care companies a lot, and some of them have really stepped up to the plate on this one. The data up until fairly recently said that home care does not help reduce readmissions. In fact, it may increase readmissions because a nurse will visit the patient's home and find them short of breath or gained weight and call the doctor whose patient it is and say, I've got this patient here. The doctor says, well, I'm way too busy. I've got an exam room full of patients. Send them to the ED, and then they get admitted. But home care companies have become more sophisticated and are much more tightly connected to the hospital and to the physicians. And I've seen some recent data showing a nice reduction in readmission. So, and of course, the home care services are paid for. The telemonitoring that you can do, home care companies will often do that as part of their service. This new pilot that we're doing is an interesting one. We'll see how that turns out. Other people visiting, there are physician services, physician home visits, the organizations that do that, and they charge Medicare, so there's no cost to you. And then phone calls, which is what most everybody does. You need to set that up. The nurse in the clinic could make phone calls. If you have a transition coach in the hospital, they could, and case managers could. If you have case managers, you can assign case managers to do all of this role. There's nothing unique about it except the focus on educating the patient, setting up the appointment, the stuff we've gone over, and keeping in touch with the patient at home to make sure that they understand their medications, they're weighing themselves every day, they know who to call if they have trouble, and the costs are not high for that.
Thank you, Dr. Bernard. So it looks like, Carl, you have a comment relative to this and transitions with the VNA.
Yeah, we have, we're in the process of a grant that, it's called the CCTP Grant, Community Care Transitions Program, which allows the VNA, actually the VNA is the submitter of the grant. We're one of 6 hospitals and the only one that's currently underway with it. But we have a VNA nurse whose responsibility it is to do transition coaching, if you will. When our case managers identify the patient in the hospital, we're able to hook them up with the transition nurse who does multiple visits and phone calls. And based on the fact that they are reimbursed by CMS under the grant, this is a gratis service for us. So we're working with actually a fairly substantial part to be able to put this plan into effect. It seems to be having a pretty good effect with with our patients. It's too early for data to come out. In addition to that, we're working with, oddly enough, our ambulance company. We're part of a consortium that owns Monarch Ambulance Services, who are also the 911 provider in western Monmouth County. They have a dedicated group who are doing our callbacks. Right now we're on a 3-month gratis program to see how it's going to go and see what the charge would be. But they're able to, I mean, they're set up to do callbacks. They have all of the software, they have all of the hardware available, and they're calling the patients and asking them how they're doing as quickly as possible when the patient is discharged. And based on algorithms that we built with them, they're referring the patient to the appropriate, either the appropriate level of care or to the appropriate resource within the hospital. Again, doing everything we can to diminish that ED visit.
Great, thanks so much, Carl. Okay, we'll probably have 1 or 2 more here, so if you have a question, feel free to go ahead and type it in. We're trying to manage these into groups as much as possible here. Carl, this one is for you. They're asking about, we've had several questions related to change in process when, what have you changed at your hospital in order to accommodate your new readmissions program?
To a large degree, the change is in the case management department. Actually, we, as of I think last week, we're no longer considered case management. Our folks are care coordinators, and it's a whole new model that we're moving to. Yes, utilization review is a piece of that. However, it isn't the overwhelming piece of the information, because a lot of these people are Medicare, and their case, the UR piece of that isn't terribly difficult. So it's a change in the focus for the individuals that have been doing care management for a long time. That's one of the areas that we've done to accommodate. The other thing is making sure that the staff on the floor, the nursing staff, the physician staff on the floor, are aware of what the role is of the care coordinator. That's an area that's easy to get into some difficulty with, is if you deploy a group of care coordinators to go out and ask whether or not the patient has received his or her education about CHF, have they received their appointment, and they're asking a staff nurse this information, and then the staff nurse becomes somewhat defensive, you know, are you here to check up on me? So we overcome that hurdle to a large degree, but it's education, 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 and making sure that everybody in the hospital is aware of what the role is.
Fantastic. We are getting to the end here. We're probably going to call it right now. We've had a lot of great questions today. Thank you so much for everybody for participating in that. Carl and Dr. Bernard, thank you for each of your parts. Today's been extraordinarily educational and successful. And thank everybody for joining the webinar.
Yeah, thank you very much, everybody.
Thank you.
Bye-bye now.